Pia. She's a very experienced data coordinator from the SDMC in Seattle. She'll be talking to you about adverse event reporting. Go ahead and take it away, Kat.
Okay. Hi, my name is Iris or Kat Sikia, and I'm a data coordinator at the SWOG Statistics and Data Management Center in Seattle. Today, I'll be talking to you about adverse event reporting on SWOG clinical trials. Next slide, please. In this presentation about adverse events or AEs, I'll be going over some important definitions and background information about adverse events, pointing out where you can find relevant information regarding adverse events in SWOG protocols and important components of reporting adverse events. Next slide, please. First, I'd like to go over some important definitions and background relevant to AE reporting. Next, please. Next, please. So what is an adverse event? FDA and NCI defined an AE as any untoward medical occurrence associated with the use of a drug in humans, whether or not considered drug-related. An AE may be a new event which was not pre-existing at initial study drug administration, a pre-existing event which occurs with increased intensity or increased frequency following a study drug administration, an event which is present at the time of study drug administration, which is exacerbated following initial study drug administration. Now, here are some examples of adverse events. Notice that even events that have nothing to do with the patient's cancer or treatment, such as breaking a leg or seasonal allergies, must be reported as adverse events. Sometimes, a patient will experience an unexpected severe reactions to protocol treatment. These adverse drug reactions are called serious adverse events. Kerry Williams, the SAE program manager at the operations office in San Antonio, will go into more detail about SAE and how to report them in her presentation. Next, please. Another important term to define is toxicity. The term toxicity and adverse event are used almost interchangeably throughout protocol, but there is a technical difference. A toxicity is defined as adverse symptoms caused or possibly caused by the drugs or treatment used in the study. When the protocol indicates we are collecting toxicities, we also mean we are collecting adverse events. Next slide, please. It is important to note that there are two types of adverse event reporting for SWOG trials. SAE and AEs of special interest require expedited reporting, which is done through CTAP errors. Kerry will cover this in more detail in her presentations on SAEs. The second type of reporting is routine reporting, which we will focus on in this presentation. Next, please. So why is it important to collect routine AEs? Every trial has an objective regarding adverse events. We always want to consider the safety of our experimental regimens as well as effectiveness. For phase 1 trials, the primary objective is to determine if the drug or procedure is safe as well as determining the maximum tolerated dose of the experimental drug. For phase 2 single-arm trials, AE reporting is most pertinent to secondary objectives that focus on estimating the frequency and severity of toxicities in the trial regimen. In the phase 2-3 randomized trials, AE reporting is also most pertinent to secondary objectives, estimating the comparative frequency and severity of toxicities of each regimen. Next, please. Now that we have covered important definitions and background information regarding AEs, I'd like to discuss an important resource to AE information required on SWOG trials, the SWOG protocol. SWOG protocols contain multitudes of information regarding how to handle adverse events seen while a patient is on trial. I will now go over some of the important protocol sections relevant to adverse events reporting for SWOG trials. Next, please. Here are the sections I'll be going over. This includes Section 3, Drug Information, Section 8, Toxicities to be monitored and dosage modification, Section 9, which is the study calendar, Section 16, Ethical and Regulatory Considerations, and although not technically part of the protocol document itself, I will also go over the protocol master form set and how it is useful for finding trial-specific information about AEs. Next slide, please. First, Section 3, the Drug Information section. This section includes information regarding drug supply. Additionally, it lists human toxicities that are already known to be caused by the agent used on the study, often presented in a comprehensive adverse events and potential risk, or CAEPR list. Next slide, please. The CAEPR is an NCI-generated list of reported or potential AEs associated with an agent currently under an NCI IND/IDE. The specific protocol exceptions to expedited reporting, or SPEAR, is a subject of AEs within the CAPR that contains a list of events that are protocol-specific exceptions to expedited reporting. Kerry Williams will cover the CAEPR and SPEAR in detail in her presentation on SAE reporting. Next slide, please. Section 8 is the toxicities to be monitored and dose modification section. Like Section 3, it also lists certain toxicities that may be observed on the trial. Section 8 will always tell you which version of the AE criteria is being considered for that study and where to access it online. All newer SWOG protocols utilize CTCAE version 5. Older protocols use CTCAE version 4, and there might even still be some studies that use version 3. An important item this section details are the dosage changes that may be required during treatment should a patient experience an adverse event. Additionally, in newer SWOG protocols, adverse event reporting requirements can now be found in Section 8. Next slide, please. It is very important to review the information in Section 8. If Section 8 dose reduction instructions are not followed, the patient may receive too much protocol treatment. Not only will this be very bad for the patient, but it could also skew the toxicity profile on the study. Required changes are sometimes displayed in a dose modification table within this section. In this example, the different dose levels are listed on the top table, and the dose modification chart for the possible adverse event of renal impairment is listed below. On the left-hand side of the renal impairment, dose modification table, adverse event grades, or the severity of an AE are noted. We will cover grades in more detail later in this presentation. You should always use the highest grade that was experienced during a treatment cycle to determine a dose modification. In this example, for grades 1 and 2, there is no change in dose level. For grades 3 or 4, however, there is a dose decrease of 1 level. So, if the patient experienced a grade 4 renal impairment while receiving the full 1,000 micrograms a day dose, after the patient's renal impairment resolves to grade 2 or lower, for the dose modification table and associated renal impairment dose modification table, the drug will be resumed at the next lower dose, noted here as a dose level at level 1 at 750 micrograms per day. As you can see in the bottom page, dose modifications are also sometimes expressed as a percentage of a previous dose. In this example, if a patient started on cisplatin at a dose of 75 milligrams per meter squared and experience a grade 2 neurotoxicity, you would reduce the cysteine dose at 56.25 milligrams per meter squared or 75% of 75 milligrams at meter squared. Some protocol section 8 instruction may indicate an increase of the dose after a dose reduction once toxicities have resolved. This is referred to as re-escalation. If those re-escalation instructions are not followed, the patient may be given too little protocol treatment, and the treatment may not appear effective or seem less toxic than it truly is. So it is extremely important to follow the dose reductions and/or re-escalation instruction described in this section. Next slide, please. Section 8 also lists toxicity management instruction. These instructions may include holding drug for a period of time or agents to relieve symptoms. This section will also tell you which version of the CTC AE you will need to use for AE reporting. If you have additional questions regarding anything in Section 8, please direct them to the study chairs and co-chairs, who are the physicians responsible for the study. Their contact information is listed in Section 8 and the title page of the protocol, and this will include their names, their email addresses, and phone numbers. Next slide, please. Another important section of SWOG protocols pertinent to adverse event is Section 9, the study calendar. The study calendar lists important events that occur on the study and is intended to be used as a quick reference and scheduling guide. However, please note that this is not the main resource for study adherence. For example, for data submission requirements, please always be sure to refer to Section 14 of the protocol. And if you want to know what scans and evaluations are required for disease assessments, please go to Section 10. A typical calendar contains required pre-registration activities, the protocol treatment schedule, specific labs to be done, a schedule for disease assessment, and most relevant to this talk is how often you should assess for adverse events. You might notice the note at the top of the page. Some protocols may not specify windows for assessment. If that is the case, you will want to refer to the SWOG best practice document. Next slide, please. When evaluating a patient for the AEs that occur during a treatment cycle, the assessment should always be performed at the end of the reporting period, not the beginning, the end. In this example study calendar, the week 1 to 4 AEs should be assessed at the end of each week. To sum up the entire cycle 1 AEs, document the events assessed on cycle 2, day 1. This way you are able to capture all the AEs that occurred during the treatment period. Do note that because some treatments can cause long-term or delayed effects, some protocols may require you to continue to assess toxicities even after the protocol treatment is finished. Most frequently, this is required a minimum of 30 days post-treatment or until the patient starts treatment on a new drug. Ongoing toxicities that were already reported during treatment should only be listed on the follow-up form if they increase in grade. Late effect toxicities have not been previously reported should be included in the follow-up form once the patient is off study treatment. Next, please. Section 16 addresses ethical and regulatory considerations. This section contains instruction for reporting serious adverse events and adverse events of special interest. More about this will be covered in Carrie's presentation. In all the SWOG protocols activated up through as recently as 2019, adverse event reporting requirements were listed in Section 16. Next, please. Finally, the master form sets, aka the all forms packet, can be important tools for understanding AEs on trial. Master form set for open and closed protocols are located in the Case Report Form tab located within the protocol document page at ctsu.org. Here is one example of an AE form from the master form set for SWOG protocol. Although all data is submitted online, paper forms are still available if you would like to use them as a worksheet. These forms are a good resource to see what data elements are required to be reported for each adverse event, as well as protocol-specific instructions and AEs of interest. Sorry. All new protocols use RAI for data submission. However, most open protocol currently using the SWOG data submission program will continue to use it until they are close to follow up. Next slide, please.
5 minutes, Kat.
Okay. Now that you know what toxicities and adverse events are, where to find information on how to monitor them, I'll talk about how you should report events to us as SWOG. First, I'll discuss the criteria. CTEP, the Cancer Therapy Evaluation Program, provides a criteria that we use to grade adverse events. Next, please. All SWOG studies uses the common terminology criteria for adverse event, also known as CTCAE for adverse event reporting. CTCAE provides a list of specific adverse event, also known as CTCAE terms, a description of each AE term, and guidelines on how to grade each event. You can obtain more criteria information about the CTCAE from the website shown on the slide, ctepcancer.gov. Additionally, you can also download your own copies of your criteria from this site. There have been several versions of the CTCAE used on SWOG trials. There were version 3 from October 2003 to October 2009, version 4 after that, and some protocols still uses that, but the most recently open protocols, they use section 5. So please always be sure to check section 8 of the protocol to make sure that you are using the most recent CTCAE version. Carrie can answer more questions about which AEs are reportable. Sometimes the conversion to CTCAE version may affect that. Next slide, please. Since all new SWOG trials use CTCAE version 5, I wanted to show you a page of the CTCAE version 5. As you can see, CTCAE terms are organized by system organ class section as denoted by the bold title at the top. The one exception to this is the investigation section of the CTCAE, which covers adverse events as captured by lab tests like CD lymphocyte decrease. Here we are looking at renal and urinary disorders section. CTCAE terms are also organized alphabetically by adverse events with definitions provided below the term. For example, dysuria noted on this slide is defined as a disorder characterized by painful urination. The navigational node is a new feature found in CTCAE version 5. These nodes can guide you to other appropriate terms related to the specific AE. Additionally, each AE listed indicate possible associated grades, which range from 1 through 5, as well as clinical description of the adverse event at the grade. I'll talk more about this shortly. Next slide, please. One thing about CTCAE term is that they may not always be noted in the way you expect. I have listed some clinical conditions and their associated CTCAE terms. As you can see, pneumonia should always be reported as lung infection. Thrombocytopenia should be reported as platelet count decrease. Shortness of breath is dyspnea. Another thing to note that each CTCAE system category includes an other option. For example, investigation other. But please don't use other. You can only use it as a last resort. We prefer that you use the actual CTCAE term. And if I do see an other on there, I will query you, but of course, and suggest a different term that may be applicable to whatever AE you are reporting. But, that's just a suggestion. You don't have to do it. Next slide, please. I briefly mentioned CTCAE grades earlier. CTCAE grades describe the severity of the AE. Here I have listed the general CTCAE grading criteria as we saw in the excerpt from the CTCAE version 5 manual earlier. There are specific clinical description of grades for each AE. However, it is important to note that not all grades apply to all AEs. Next slide, please. If we go back to our previous example, you can see grade 5, if applicable to that AE, is always death. Specific description of grades can be lab-based, such as chronic kidney disease. The grade is based on eGFR, or the creatinine clearance. Some AEs are more clinical and should be graded by the treating investigator. However, as you can see here, not all AEs have all grades. Acute kidney injury is a good example. If a patient is noted to have acute kidney injury, they automatically have at least a grade 3. And as you can see, dysuria only have one grade, and thus a grade 1. Next slide, please. In addition to grading adverse event, many studies require an attribution code. This is not part of the CTCAE, but is something most trials request. An attribution code is the description of the relationship of the AE to the entire regimen of the protocol treatment. Attribution codes range from 1, meaning unrelated, to 5, being definitely related. Depending on how data is collected, you will select the attribution from the drop-down menu. Please note that the attribution code must be assigned by the physician, not the patient or the CRA. Next slide, please. Some SWOG studies also collect status code in addition to grade and attribution. These are monitored by the CTEP, Clinical Data Update System, also known as CDAS. Status codes are collected in studies called complete reporting studies. If the study uses a baseline abnormalities form, it is a complete reporting study, and status will be collected on the AE form. Status is the state of the adverse event at the various points throughout the study. The AEs can be new if this is the first occurrence of the event on the study, continues at the same or lower grade if it was previously reported AE, continuing at the same or lower grade, or increased grade or improved then worsened if it was previously reported AE that may have worsened since it was last reported, or improved and then worsened again. Next, please. Some additional data items that may be collected for each AE include serious. Is it an SAE? Hospitalization. Answer yes if AE caused a patient to be hospitalized or extend their hospital stay by more than 24 hours. Is the AE immune-related? For studies that include immunotherapy drugs, you may be asked to specifically identify immune-related adverse events. Onset and end dates, registration intent trials, collect onset and resolution date for each AE, as well as marking as ongoing if continues through next cycle. Action taken. How did this AE affected the drug? Next slide, please. To wrap up this section, here are some general rules for adverse event reporting. It is helpful to record events as they occur. Do not wait until all the cycles have ended to report the AEs and try to remember what the patient had complained about. Please be sure to list all adverse events regardless of clinical significance. However, an exception to this is pre-study symptom or abnormal lab values. Anything existing at baseline prior to treatment should not be recorded as an AE unless it worsens following treatment. Some studies require a baseline abnormalities form to be submitted to assist you with keeping track of conditions existing prior to treatment. For most studies, we only want most severe grade experience since the patient was last assessed. However, please refer to the AE form instruction for your specific study, as there are some studies with exception to this, like S1418. Please avoid using other adverse event term whenever possible. These are adverse events that appear in the criteria, such as pain, other, or metabolic other. If you can find a term in the criteria that more accurately describes the adverse event, please use that term instead. It may also help to use the category lookup in these cases to find better match. However, if the adverse event is not listed elsewhere in the criteria, please document it by using these other AE codes and add a comment to specify what is going on. If you are unsure, document an adverse event. Forms can always be amended. Next, please. So that concludes my talk about reporting adverse event on SWOG trials. If you have any additional questions or concerns, please feel free to email us at the SWOG Data Operations Center in Seattle. Listed here are the disease sites and study-specific distribution lists. This distribution list will put you in touch with the assigned data coordinator as well as their backups if they are unavailable. Thank you.
All right, thank you very much, Kat. Our next presenter is Carrie Williams from the Operations Office, and she'll be discussing serious adverse event reporting. Carrie.
Hi, I'm Carrie Williams. I'm the SAE Program Manager at SWOG, and so we'll discuss SAE reporting. So a serious adverse event is basically, it's a subset of the adverse events that you are collecting on your patient. So it's important as you collect your adverse events that you should assess them to see if any of the collected adverse events will meet criteria for further reporting as SAEs. Next slide, please. So SAEs are graded based on CTCAE 5.0. You can get a PDF copy of the CTCAE at ctep.cancer.gov. The system, the CTEP air system, is loaded with CTCAE 5.0, so you won't have a choice, in the version that you report. Next slide, please. SAE reporting criteria is found in section 8 of the protocol now. Some of the older protocols, it may still be in section 16.1. So if you don't find the criteria in section 8, scroll through and down to section 16.1. Next slide, please. This is an example of the reporting table that you'll find in the protocol for investigational agents. You'll notice that the top portion of the table, it lists the seriousness criteria. So this is an item or items that your event meets in order to make it serious and make it reportable through an expedited report. The middle portion of the table provides you information on the reporting timelines. And then the bottom third-ish of the table gives you some additional instructions for reporting a late effect. So basically an event that occurs outside of the stated reporting window, but it's felt that the event is either possibly, probably, or definitely related to the protocol agent. Next slide, please. This is an example of the commercial reporting table. This one does garner a lot of questions to us. In this case, you're reporting events that are grade 4, unexpected, and at least possibly related to protocol agent or grade 5 events. It also includes information about late reporting if you find something that is possibly associated to protocol agent and again falls outside of the reporting window. So there's fewer events that will meet criteria for reporting when this table is being used. Next slide, please. Additionally, in this expedited reporting section of the protocol, we will list events that are AEs of special interest. So in this example, in subsection 2, we would list events, sometimes with grading, sometimes without, and these events are reportable. They're AEs of special interest, so you will be reporting them sometimes regardless even of the grade. There are other times for subsection 3 where an event is a very well-known toxicity, and so it's considered an exception to reporting. And so we'll, in that area, if we have events that we don't require you to report through expedited report, we will list them there. Next slide, please. Deaths on study are all reportable, and that includes a death due to disease progression. So any death that occurs within the time frame stated in the protocol, and in general, that would be within 30 days of the last dose of study agent, it's required that you report them with a CTEP errors report. Next slide, please. There's also a subsection that will address pregnancy reporting, so you should refer to that section. There are some special items in there as far as how to report a pregnancy. Pregnancies at this point in time are reported for the female study participant only. They'll be reported through a CTEP errors report, as well as an NCI pregnancy reporting form that's available on the CTEP website. You would fill that out and follow the instructions on that form on where to send the form. Next slide, please. When you are making an expedited report, there's two pathways that your report will follow, either the 24-hour pathway or the 10 calendar day pathway. Unless you have overridden a recommendation for reporting, this is an internal mechanism in the system. So based on the event and the information that you give the system, it will put you on the appropriate pathway. Keep in mind that a 24-hour notification report and the 5 calendar day report are really a reporting set. So you first fill in the 24-hour notification report, you submit that, and once that's submitted, it creates an exact copy that is a 5 calendar day report, and that one will remain pending in the system for you to make any updates to it, but it has to be submitted within the 5 calendar days. If you have all the information that you believe you're going to have for a while, it's appropriate to go ahead and send the 5 calendar day right after you do the notification. You don't have to wait, but it is there for your convenience if you think that within the next day or so you would have some additional information. The system sends you emails letting you know of submissions and reminders that you have reports pending. Patty and I monitor the system as well, and we will send you emails as well, especially when it looks like you have a report that's in jeopardy of timing out. Next slide, please. So SAE reporting is done electronically through the CTEP errors system. For some of the older protocols that we still have going that do not utilize the RAVE CTEP errors integration, you're going to be reporting those by simply going to the CTEP errors system. Next slide, please. So you'd log into the system, and I guess people who've been doing this for a little while will know you come to this first landing page, and you either are going to report adverse events, which is basically starting a new report. If you have a report in the system, if you're looking to look something up or to amend, then you would click on Manage Reports. Up in the upper right-hand corner of every page in the CTEP errors system, there's a Help button. This opens up the whole guidebook for how to submit CTEP errors reports. So it's a nice guide that you can open up and use as you're reporting. This page also has some helpful information on some resources and how to contact the help desk. Next slide, please. So when you're reporting an event or events, it is possible that the system, which is loaded with very basic rules for reporting, it may tell you that an action is not recommended. This is simply a recommendation. This is not telling you that you cannot report. It's just saying that based on some simple rules, the system doesn't think that you need to be reporting the event. You'll notice that underneath where I have the red arrow, it does tell you that there are possible exceptions to this recommendation, mainly based upon the protocol. So you always want to consult the protocol, and you always want to report based on the protocol. If you're going to go ahead and report because your protocol says that you should, you simply scroll or kind of look down the right-hand side, and there's a little tiny override. So if you click on the override, it will override it, and it will just put you right into the system, and then you'll just go and report as usual. Next slide, please. So newer protocols, you are still reporting electronically, but the newer protocols utilize the RAVE CTEP errors integration. And so what this is going to mean is that you have to start in RAVE in the cycle on which you are associating your reported events. You're going to roll out the treatment forms, and this is regardless of where you are in that cycle, and you're going to get started on those treatment forms, and you're going to actually start a portion of your reporting in RAVE. Next slide, please. So you would roll out your treatment forms, and you may have some information. There may be some information you don't have as far as cycle information. That's fine. We understand that because you may be reporting mid-cycle. And then you're going to be putting things on your adverse events report form. And then once you're done, you're going to be using that expedited reporting evaluation form. Next slide, please. So as you fill out your AE form, you're going to fill in, of course, the event, attributions, grade, dates, everything that's being asked for. And then because you are indicating that you're reporting an SAE, you're going to want to toggle one of the items that I have arrowed. So the hospitalization, life-threatening, on down the line there are seriousness criteria. These are the same seriousness criteria that are listed in the top of the table that I showed you for reporting on investigational agents. So what you're telling us is your patient had an event, and I am toggling, say, hospitalization, because that is the criteria that that event met in order to be serious and require expedited reporting. Next slide, please. So currently we have a little bit of a problem in the system that is going to be corrected in future protocols. But required intervention was the seriousness criteria that was included in your view for treatment protocols. Required intervention is actually meant for device protocols. And so it's when any drug treatment protocol, this is not an appropriate seriousness criteria to choose. And to make it even more confusing, if you click on the little question mark to get the definition of required intervention is really the definition that should be under other, because other indicates an important medical event, and that is a definition for important medical event. So we do have a small set of about 4 slides that we send. So if we kind of get into trouble with this with you on a report, we have a small little subset of slides that we can send you that just address this issue. Next slide, please. When you're putting in your AE information, and if you have a number of AEs, some serious and others that are considered non-serious ones should be checked none. What that tells us is that this is an adverse event, but it does not meet any of the seriousness criteria. So it's considered a non-serious event. Next slide, please. So once you have your AE form filled out and you've submitted it or saved it, then you're going to want to run the expedited evaluation reporting form. Okay, so think of this form as the linkage between RAVE and CTEP errors. When this form is run, this form does what the CTEP error system itself used to do. It sends all the events that you've listed on your AE form through that rules engine, looking at what you've put on there and looking to see if it thinks that anything might need to be reported through expedited report. Again, it's going to come back and it's going to tell you if a report has been recommended. It also contains the language telling you that it's a recommendation. You should still consult the protocol. If the protocol does not recommend or it doesn't require you to report something, then on this page you can toggle create, change it to none, indicating that there is not going to be a report submitted. But in most cases, you've got an SAE that you filled in. You've got all that filled in. The recommendation is correct. It provides a link for you to click that takes you over to the CTEP errors side. Okay, and it will push certain information out of RAVE and you right over to the CTEP error side then to get started on the rest of your report. Next slide, please. Once you run the expedited evaluation reporting form, it will automatically populate a no or a yes in the SAE report recommended column. Again, this is simply a recommendation. You report SAEs based on the criteria of a particular protocol. And if it has a yes in this column and you do not believe it's reportable, consult the protocol. And if you still are unsure, please contact either Patty or myself, and we can take a look and take a look through the protocol and make sure that you're on the right track. Either it's reportable or it's not reportable. Again, the rules that do make the decisions for recommendation are very, very basic. So they're usually right most of the time, but you're going to run into ones where they're going to say yes or no, and it's not going to be appropriate. Next slide, please. So this is just some things to keep in mind. Report based on the protocol. If you're amending a CTEP errors report and you're in the report itself and you find that there are areas in that report that are grayed out or don't allow you to access them to make a change, what this is telling you is this is a report that was done through the RAVE CTEP errors integration. Anytime you find something that is locked to you on the CTEP error side, that's telling you to first go to RAVE and make the correction in RAVE. Rerun your expedited reporting evaluation form to push your changes over to CTEP errors, and the changes then should be seen on your CTEP errors report. Next slide, please. In the reporter information section of all the CTEP errors reports, there's two places where a person's name, email, phone number can be added, the reporter and the submitter. With a lot of sites kind of diversifying their workflow and having multiple people involved in patient information and data, it's important that you make sure that the reporter and or submitter are good contacts for that report, because we use that report to contact you for requests for amendments, for queries, for supporting documents. And so we can't keep up with everybody's workflow. So please make sure that those are good, valid names, emails, and phone numbers. Next slide. Next slide. Currently, we do not have any protocols where we are asking you to report SAEs after a patient signs informed consent, but prior to intervention. So if you come across a time when you begin a protocol and these are your only two choices, TAC 0 or other, you will choose other, and then you will have to key in the protocol treatment that your patient was randomized to receive. Next slide, please. Don't forget your seriousness criteria. You will either be putting this in yourself if your report was done directly through CTEP errors, or toggled on the AE form if you're reporting through the integrated system. It's important that this is toggled because, again, you're telling us that you're reporting an event because it's serious, and in order to be serious, it should meet one of the seriousness criteria listed in the protocol. Next slide, please. This is the same slide that from the previous talk that it just shows you that we use 5 different categories for attribution. Next slide, please. You will find that for an event, you must have a positive attribution. So there may be times when you don't have a positive attribution. So other than death not otherwise specified, sudden death, or fetal death, you will have to select a positive attribution. Next slide, please. So when you're entering your information, if you are saying that an event is unlikely or unrelated to either the cancer under study or the treatment agents, you will then turn to look at concomitant medications or a contributing cause. Any information that's added as a concomitant medication or any information that you add in the other causes section, those are other sections that once you have entered data will require you to have an attribution. So sometimes that's the way that you will have to report an event. It may not be due to treatment, it may not be due to the cancer, but say perhaps a pre-existing condition. Your patient, if you're reporting some type of heart problem and your patient has a pre-existing condition of heart disease, then that may be listed in the other causes and then added as a cause that contributed to the event reported. Next slide, please. We follow the guidelines of 1 ticket per cycle or course. So it's important to keep track of reports. If you have several expedited reports for a patient, make sure that you are consolidating everything that occurs for your patient on a single cycle, on a single report, and you amend that report as needed through the cycle. And then, once the patient moves on to the next cycle, and you would start another ticket if they had SAEs on the next cycle. Next slide.
5 minutes, Terry.
Remember to put resolutions to your reports. So once you've submitted an expedited report, you want to make sure that, as new information comes in or as appropriate, you can somehow close the loop on a report, providing follow-up information, end dates, updating your patient's status, whatever you can do to bring as much resolution as possible to a submitted report. Next slide. Supporting documentation that is required by SWOG, you will receive an email from either Patty or I once we reviewed your report, and we send it to you. We try to make at least a quick overview of the types of documents that we think that we're going to need in order to have the case reviewed, and we give you information on where to send your supporting documents. And this is a separate request from anything that you send or upload in NCI tab. Next slide. Remember to redact patient privacy information. We do ask patient ID, protocol number, and ticket number appear on each page of the supporting document so we can make sure that we keep all the documents together for a single case. Next slide. An SAE report is run prior to any audit that comes to your site. We look at all the SAEs reported at your site, and then we also look at any that are reported late. So our system looks at some dates and will flag a report that it thinks is late. We take those reports, Patty and I review them, we make comment to them, and they are sent to your site prior to the audit and with some instructions, and you guys are allowed to take a look at them, send us any updated information so we can either confirm that yes, indeed, the report was late, or you can give us any added information so that we can clear it. So our goal is to have completed this, your SAE report review prior to the auditors even coming on site. Next slide, please. So just to kind of wrap this up, always consider the possibility that any AE that you've collected could possibly also be an SAE. So always review them and report as required. If you find you have an AE that is also an SAE, you should initiate a report within 24 hours of onset or discovery of that event. If for some reason you're unable to access the internet, you can call us, the SAE program at the operations office. Our contact information is in the SAE reporting criteria section of all the protocols. Submit your reports within the specified number of calendar days. We hate to see your hard work get dumped out of the system. And please send your reporting or your supporting documentation as requested, as soon as you can, so that we can get your cases reviewed and any questions that we have resolved. Next slide. As I said, I work with Patty Felt in the SAE program. So this is our contact information. Next slide. Just some resource information for some guidance. and a way to get to the CTEP's website to the see adverse event reporting to get a PDF copy of the CTCAE. Next slide. And email and phone numbers for technical questions, for medical questions and technical questions for CTEP errors. It's always good, I think, if you're having problems or you have questions, contact Patty or I first, so we can take a look at what's going on, what kind of questions you're having, so that if we can't help you solve your problem, we usually have a pretty good idea of where to send you, whether it's maybe a data problem or a technical problem with one of the applications. Okay, I think that's it.
Okay, thank you very much, Carrie. It doesn't look like any questions have come through on the chat, so we can go ahead and move forward with our next speaker. Also from the operations office is Elaine Armstrong to talk about audits and a quality assurance program. Elaine.
Thanks, Rodney. Hi, I'm Elaine Armstrong, the Quality Assurance Program Manager, and I'm going to talk about the audit process. And hopefully you will feel more comfortable if you have an audit coming up, if you kind of know what to expect. Next page, next slide. So the purpose of the audit program is for us to verify the study data that could affect the interpretation of the primary study endpoint. So we look at, to make sure you're compliant to the protocol, we look at regulatory requirements, and we verify you submitted accurate data. We also look at, to make sure that you're following good clinical practice. And we can also provide educational support, because this is the one opportunity you have for someone to, look at your records one-on-one, someone from the outside. So a lot of times we can give you some guidance in some ways that you might not, get from in-house. Next slide. So first thing is, when are you going to be audited? If you're a new LAPS member or a new NCOR, you'll be audited within 18 months of your first patient registration. If you're an affiliate or component of one of those main members, then you'll just get rolled into the next audit when they're audited. You will be audited at least once every 3 years. Some of you may have been part of a pilot study. There was a pilot study to look at doing multi-group audits, but that pilot is over and it was decided not to continue with that. So you will continue to be audited by each individual group that you're part of on an individual separate audit. And then if you're participating in any of our FDA registration studies, those are monitored more frequently than on your treatment audits. Next slide. So if you're participating in the registration studies, that's right now for 1400 and lung map, you will be audited within 3 months of your first registration to a sub-study, and then you're on a 6-month basis. And then the other 3 active studies are 1418, 1806, and 1914. And the initial audit is 6 to 9 months after your first registration to one of these studies. Then 1404 and 1605 have been closed for a while, but there's just a handful of audits we're trying to finish up with that just to fulfill the NCI requirement of every 3 years. Some of those audits were postponed last year due to COVID, and so there's just a few of those we're trying to finish up in the next couple of months. Next slide. So if you're a part of a, if you're the part of the main member or main labs, if you're a big NCOR, we go, would do your audit on site. And then affiliates, the NCOR components usually will bring your records to that main member site. Now, if you're a really large accruing site, an NCOR component or an affiliate where you're, if we have to audit 6, 8, 10 charts, then we prefer to, a lot of times we'll come on site to your location so that you don't have to carry so many records to your parent institution. And then we like to get to, if you're doing FDA registration studies, we try to come on site at least once for one of the studies that you're participating in, to look at your pharmacy and verify your investigational agents. But most of the time you would be audited with your parent member. Although, as I guess you're probably aware, the majority of our audits have been done remotely in the last year due to COVID. So we'll kind of be transitioning probably back into more on-site audits going forward. Next slide. So we will, if you have an audit coming up, we will contact you to 3 to 4 months in advance. And then, we'll come up with a mutually agreeable date, so you've got it on the calendar. And then 4 to 6 weeks before the audit, we send your list of cases with a lot of details of what kind of information we need submitted to us prior to the audit. And just, try to get everything set up in advance so everybody's ready to go on the day of the audit. Next slide. The audit team will consist of a QA representative, which could be me, or there's a couple others in the department. And then we have 6 full-time nurse auditors and 1 contract auditor that do the patient case reviews. And occasionally we use a volunteer auditor. But it's nice, we have in-house nursing staff, so that brings a lot of consistency to the audit process because it's the same auditors for all of our sites, since we use very, very few outside volunteer auditors. And there's always a possibility that the NCI might send somebody as an observer. Next slide. And then as far as who needs to be part of the audit process at your location, of course, your CRAs, your research nurses, your PI or a designate, your regulatory staff, your pharmacy staff, all of those people need to be involved at, it's some aspect of the audit. Next slide. And so the next thing I'll talk about is just the audit process, what you can expect when we actually, come to conduct the audit. Next slide. So there's 3 parts to the audit. The first is the regulatory review, which is looking at IRB documents, consent form content, and the delegation of task log. Then the next is the investigational drug accountability, which is looking at the record keeping. And then if we conduct an audit on site, then we will visit the pharmacy. And then the last part of the process is the patient case review. Next slide. During the IRB audit, we're going to look at all the regulatory documents for all the protocols on the case list. If we're looking at a patient case, then we will also look at the, those same regulatory documents for those protocols. And then we'll usually have 1 or 2 long-term follow-up protocols for studies that you're just for patients that are just in follow-up. For informed consent content, we look at 3 to 5 consents where we go in and look very carefully at all the, page by page to make sure that the consent forms contain all the required information. Then we will look at either the delegation of task log for investigational studies or the site authority log, which is a more general log. And then if you're doing any FDA registration studies, we will verify that you have a trial master file in place. Next slide. So if you're looking, there's not a lot of studies left that are still under the local IRBs. There's a few cancer control studies that have not transitioned to the CIRB. And if it's the local IRB, we need to look at the initial approval and the continuing reviews. We'll verify that you have documentation for any protocol updates, such as revisions and addendums. If there are external safety reports that meet the reportability requirements by your IRB, we'll verify that. If there are internal SAEs, as Carrie talked about, then those would need to be reported to your IRB based on the reportability requirements. We will need to see all versions of your IRB approved consent forms for the entire audit cycle, which is going back 3 years. But another option is if you can just provide us a comprehensive list of all the versions of consent forms that you've had over those 3 years. And then if you have any alternative procedures, such as most IRBs now only require you to submit SAEs and external safety reports if they meet the criteria of unanticipated. And if that's the case, then we just need to be able to see a copy of your SOP. Next slide. And then if the protocols are under the purview of the CIRB, the documentation that we need to see is the study-specific worksheet, which is when the CIRB gave you, basically approved that said, yes, we are now your IRB of record. They'll look at your approved boilerplate language. And then we look at the dates that you implemented the protocols and those consent versions, because you have 30 days to implement those. And then we will verify submission of unanticipated events, such as local SAEs. One of the things I like to point out for this is all of the CIRB approval documents are located on the CTSU website, and we have access to that. So we do not need to see those approval memos and letters, because we have access if we need them. We just need those, there's just a few items that we need to look at. But once again, we do need to know about every single version of your consent form that was in place during the audit cycle. Next slide. Excuse me, next slide. For consent form content, we're going to compare your consent to the model consent to make sure it has all the required information, that it was updated when there were protocol modifications, say adding new risks. We want to make sure your specimen banking optional studies questions are the same as the model. And if you're using the CIRB, your consent form has to be identical to the model consent, except for any changes that were approved by the CIRB for your boilerplate. And so you cannot add any language that was not previously approved, and you can't remove any language unless that was previously approved by the CIRB. And you do have to have some kind of, as I mentioned before, we want to be able to see every version of your consent form. So if you updated your consent form because of a revision, we need to know about that. But if you also updated your consent form because you had a new PI, or you had a new boilerplate and you had to update your consent forms, we need to, those need to be included in the list that you provide us. Next slide. And then the delegation of task log is a relatively new phenomenon. All of the registration studies have a delegation of task log on the CTSU website. And now, going forward, all new studies that use investigational agents will have a delegation of task log. But for years, since 2003, SWOG has had a site authority log, which is just a paper log that you complete with all the key staff and their signatures, and there's delegation of authority noted, and you just need a single log for all NCI sponsored studies. It does not have to be a protocol specific log. If you are, say, an NCORE with, say, 10 different community sites, then you should be maintaining a site authority log at every one of those sites. But once again, you just need one of those logs to cover everything, all of the studies that don't have a DTL. Next slide. And then for the trial master files, you need copies of your protocol, the regulatory documents. You would have CLIA certificates with lists of normal lab values, any local SOPs, any training documents. Because so many documents are maintained centrally, either by SWOG or by CTSU, such as 1572s and CVs, those types of documents, we don't require that you keep those in your trial master file. It's okay to put a placeholder that explains where those documents can be located. So if the FDA were to do an inspection, you could say, oh yeah, all the 1572s and CVs are located with CTSU, and we could request them from there. Next slide. Then for investigational drug accountability, we're going to look at the drug accountability record keeping by either reviewing the NCI DARF or the NCI oral DARF. And at this point, any study that uses an investigational drug on any NCI sponsored study should be using one of these two logs. In the past, we did have a SWOG specific DARF, but we switched over 100% to the NCI form several years back. We will need to see the control and satellite records. We're going to make sure everything was completed correctly. You use good documentation practices. That patient returns are documented on the oral DARF. Next slide. We will verify that you have shipping receipts for all the entries that you logged in. If any drug was transferred or returned, there has to be documentation of that. It's very important that any unused or expired drug gets either returned or destroyed within 90 days of end of use. So if a patient's on a blinded study, once they go off study, you know that drug will never be used for another patient. So it should be, that's destroyed or returned immediately. And then if you have other drug, you can possibly transfer it to another study that's still active rather than destroying it or returning it. And it's very important that you not use commercial drug in place of investigational drug because that's definitely not allowed. And so be very, be very sure and read the pharmacy section and know which drug is being supplied for the study at the beginning before you activate a study. Next slide. We will cross-reference the DARFs against the patient records to verify doses and dates of dispensing. Every pharmacy has to have an SOP for authorized prescriptions to ensure that any physician that prescribes investigational drug has a current status with PMB, because they had to be active within PMB when they registered that patient, but it's possible that their approval has expired at the end of a year. So you need to make sure that those are kept active and that you have a policy in place that explains how you verify that. And then if we conduct the audit on site, we will actually conduct a tour of the pharmacy to look at security and storage conditions and to verify the physical inventory. Next slide. And then the last part of the audit is the patient case review. Although this is the biggest part of the audit, is the most time consuming, is the most work for both the auditors and for the site getting prepared. We will look at 10% of your SWOG accrual and your CTTC accrual. And within that, we have to look at 10% of treatment and 10% of your cancer control cases. And SWOG does separate on-site separate monitoring of all of our registration studies, but most groups do not. So anytime you enroll patients on an FDA registration study, we are required to select at least one case from at each site for those studies. We will look at a minimum of 3 cases at each site we audit. And if the audit is conducted on site, we look at 1 unannounced case. If the audit is off-site, you're off the hook, and we won't look at any unannounced cases. Next slide. So the categories of review during the patient case review are: we look at the informed consent, we verify eligibility, we look at the treatment administration or the intervention. There could be an intervention that is not an actual treatment study. Then we look at either disease or endpoint assessments, toxicity assessments, when applicable, and then data quality. Next slide. When you, so just a few recommendations on setting up your charts. Ideally, you would give us access. Well, I shouldn't say that. When we're auditing remotely, ideally, we would like to have access to your EMR. If we are on site, reviewing a paper shadow chart is fine, or looking at the EMR. We can work with both of those. If you are setting up shadow charts, then the way we recommend you set up your charts, if you have the option of making this determination, is that you put your consent form and your screening documents, up until covering eligibility at the beginning, and then you would put the remaining documents in chronological order by cycle or reporting period. Because if we're looking at cycle 1, we would like to be able to see the H&P, the labs, any assessments, scans and things that were done for that cycle. Because when you organize records by putting all your labs under a tab and all your scans under a tab and all your visits under a tab, we're having to flip back and forth between those different sections as we go through each cycle, because we are verifying the data you submitted in RAVE against these records that you have in your chart. And the way we look and rate is in a chronological order. We're going to go by, cycle by cycle to look at information. So that is our preference. If you do have paper charts, we do ask that you use color-coded flagging so that, one color indicates like your office visits, another color for labs, another color for scans. That helps us to find what we need. It's very important that you have your specimen submission documents flagged. When we're auditing SWOG studies, we have access to reports before we even come to your site to verify specimen submission, but we don't have access when we're auditing other groups' studies, and frequently sites forget that they need to have this information flagged for us. And then we will be auditing records in the EMR, then there's a source document locator form we ask that you complete ahead of time so that some of it's usually pretty straightforward, but something like a nurse's note may be in one location at one site and maintains completely separate at another site. So we need that information ahead of time. Next slide.
5 minutes, Elaine.
Okay, thanks. Informed consent, we want to make sure that they sign the most current version prior to registration, which is why we have to know about all the different versions that were implemented at your site. Contains all the required signatures are on the consent form. If there were requirements to inform the patients of any new findings, such as new risk information, that has to be done, and ideally at the very next visit, if worst case scenario, by the second visit. And if there were specimen banking questions, it's important that those are answered by the patient and that you report those in at the time you register the patient. Next slide. For eligibility, we're going to verify the diagnosis, looking at pathology and other diagnostic reports. We're going to review the medical history for any exclusion criteria, verify all the pre-study tests or meet the parameters of the protocol, and we're done in the required time limits, and that the registering investigator has signed the eligibility affirmation. And just remember, there are never any exceptions allowed to eligibility criteria. Next slide. For treatment administration, we will look at if there are BSA dose calculations, we'll look at those, make sure that we will verify drug orders, drug administration documentation, make sure dose modifications are done appropriately. If the patient's on oral medication, there needs to be patient diaries or calendars or something to verify, show compliance to the medication. If there are delays or deviations, be sure you have supporting documentation for that. Next slide. For endpoint assessments, we will make sure that you followed, all the requirements according to the calendar, and make sure that you use the same methods at baseline and for each assessment. So if you use CT scan for baseline, you don't want to switch to a PET CT at the next assessment. You want to be consistent. And it's important that your tumor measurements are documented by the radiologist, or if it's necessary for the treating investigator, somebody has to document those tumor measurements. And then once the patient has completed treatment, we'll make sure that all the off-treatment follow-up is done per calendar. Next slide. For adverse events, we'll make sure that all the baseline and follow-up studies were performed, that you documented grade and attribution. Most sites have an AE log that they keep in addition to any AEs that are documented, say, in your investigator notes. Remember, if it's immune-related drug, you also have to document that it has what the immune-related status is. And then we will check to make sure all the adverse events were reported correctly. And if there were SAEs, we want to check to see if they were submitted within the either 5 or 10-day time requirement. Next slide. General data quality is just, the quality of your source documentation. Do you use good documentation practices? Was the data submitted in a timely manner? Things like specimens, imaging, quality of life questionnaires, those all fall under the data quality category. So we'll make sure those were submitted, that they were obtained per protocol and submitted timely manner. And you don't use whiteout, you don't scribble over things, you know, just use good documentation practices. Next slide. So after we complete our review, we're going to meet with the PI and the staff at the site to summarize our findings. And this gives a chance for the sites to sometimes clear up things, you know, questions come up. We have to submit a preliminary report within 24 hours. So we try to get things as clear as, you know, and as we can before we leave, so we can submit that report. Next slide. And then we will write the report, and if you're acceptable in all three categories, you're off the hook. You're good to go for 3 years. If you're acceptable with follow-up needed, that would be anything with major deficiencies. You will have to submit a corrective action plan after the audit. Next slide. And if you're unacceptable, you also have to submit a corrective action plan to address the major deficiencies. And then we will also do a re-audit within 6 to 12 months. And it's by category. So you could possibly be unacceptable for patient case, and we'll have to do a re-audit, but that doesn't mean we have to look pharmacy and regulatory since they were fine the first go round. And if the patient case has to be audited on site, I mean, is re-audited, we usually will come on site, whereas like regulatory document re-audit could probably be done just remotely. Next slide. So just a few helpful hints. Always take notes. If when in doubt, make a note. Be sure and sign and date anything. If you're using case report forms as a source document, which is a common thing like for cancer control studies, just be sure and sign and date them, and then they can be considered a source document. Be sure and keep records on a real-time basis. Don't try to go back and figure out what you did 2 weeks ago. And be sure that height and weight performance status. People do much better now with the EMRs. This kind of information gets captured a lot better than it did in the past. Next slide. Be sure and do secondary reviews of eligibility. It's so frustrating to miss something on eligibility that perhaps just a second set of eyes would have picked up on. Try to look at audit as a positive learning experience. We really look at it as an opportunity for us to educate you, not to be punitive. So even though that is our job to tell you what you're doing wrong, just think of it as a positive experience, and include as many staff from your affiliate sites as you can, so they can learn also. If they live 2 hours away, it's not very difficult to get to the location. It's good if they can come in person and meet with auditors when their charts are reviewed. Be sure you conduct internal audits and training, and of course the reports. I know you get your query reports and your expectation reports. They're also available on the workbench, so take advantage of those reports. Next slide. And then the QA website, the QA page of the SWOG website has all kinds of documents that are very useful. There's the best practices documents, there's a regulatory guidance, there's patient chart review guidance, there's drug videos, PMB policies, there's links to all the kinds of stuff at PMB on our website. Next slide. And there's guidance on record retention, on conducting QA internal audits. There's a site authority log that you can download if you need a copy of that. There's all kinds of links and information about the trial master file, which there'll be an update coming out in the near future for that. And maybe I have one more slide. I'm not sure. Nope, that's it. Thank you.
All right, thank you, Elaine. No questions came in during your presentation, so thank you very much for that. Our next speaker is Sean O'Brien, a data coordinator from the SDMC in Seattle, to talk about the specimen tracking system. Sean.
Hello, everyone. I hope everyone's day has been good so far. I will be talking about the specimen tracking system once that comes up on the slides. But hopefully everyone's been stretching out, getting limber before I begin my talk. Let's see, it's on the, me go to the right slides.
Yeah, Bill, I think you went back to the very start of this session, so Sean's is like 3 or 4 in.
There we go. All right, so specimen tracking system. Once I get access again.
Oh, is Bill turning?
Yeah, okay, now I can take control, sorry. All right,
Okay.
now it should work. All right, perfect. All right, so the specimen tracking system, often referred to as SpecTrack in conversation and as the SDS in writing. So what is it? Well, the specimen tracking system is a web-based program that allows you to log specimens and keep track of shipments that are sent to the SWOG laboratories or repositories. So when you complete a log line in specimen tracking, it resolves the expectation for that specimen immediately, and it allows you to track the specific shipment left at your institution and when the lab receives them. Once the specimens are logged into the system, you and other representatives from your site, those of us at the SWOG data center and the lab, can view what was submitted, when and how it was submitted, and if and when it was received by the lab. So the history of the SDS. So the first version of the SpecTrack program was released in November 2003. So SO221, if you ever had that study, it's a breast trial. It's a pretty old study, but this was the first study that ever had used the SDS. So it's been quite a while. It's been 17 years, almost going on 18 years. So it's been a long time. But now all current SWOG studies use the specimen tracking system. There has been different versions and improvements. Most of us here today have never used the original version of SpecTrack. I haven't. That version was quite a bit different from the system we are currently using. As is the case with almost any new system, there were many kinks our team had to work out after the initial launch. And the reason why we are stressing this is because some of those changes actually came from user feedback. So your input is greatly appreciated. So whenever you guys have any questions or maybe even concerns, just feel free to reach out to the SWOG Data Operations Center or maybe even the operations office in San Antonio, and they can loop us in as well. So how do you know if your study uses the specimen tracking system? Well, there's a few ways. First is the patient consent. If the specimens are collected for the study, the consent will say so, and also will let you know if specimen submissions are mandatory or optional. Secondly, take a look at section 15, which is pretty much every study. You will find all the details on specimen submission for translational medicine and banking in that section. Lastly is section 12, which is the discipline pathology review section. It will tell you what, how, and when to submit those specimens. Generally, submissions for discipline review are sent to a different lab and are separate from those sent for banking or translational medicine studies, even if the study, the specimen types are the same. However, please review the protocol for further details. So guides and tutorials. So listed here are the best sources of information for instructions in using the system. Firstly, section 15 of the protocol will tell you what specimens are required for the study, or if they're optional, how they are to be processed, and when they are to be shipped. If you need more guidance on processing or shipping instructions, there should be a link in section 15 that provides that information. Secondly, if you have questions are only about the specimen tracking system, there is a downloadable tutorial on the SpecTrack homepage. There's also a link to a training module that you can watch and interact with in order to learn the system. Thirdly, if you use all those resources and are still having trouble, especially the first time you use the system, give the data coordinator for your study a call. While we, the data coordinators, cannot help with technical areas, we can provide general information on specimen requirements and protocol clarifications. And we can also walk you through the system using our test database, which we'll go over in a second. All right, so this is what the CRA workbench looks like. You can access the CRA workbench directly from SWOG.org or go through the CTTC website. SpecTrack is one of the links you'll find on the workbench homepage. From the CRA workbench, you could see in my animation that the specimen tracking link is on the left. So once we click that link, on the top right corner, you can see that this is the test specimen tracking link. And then you also have your username and password. And once that is all set and you put those information in, you say, I agree, and log on. So you may get a list of institutions like the screenshot provided, where you will need to select the site responsible for the patient. Make sure you are selecting matches the open registration entries for the patient. If you are only associated with one site, you will not get this list or the dropdown and will be automatically directed to the test database. So this is what the specimen tracking homepage looks like. As you can see at the top and the letters, the top, this is the test website. So make sure that if you click the incorrect entry, make sure you're looking at the top of the screen, just to make sure it's not the test database. There's 2 links you will choose from. Most are Log a Specimen and Specimen Manager. We will be covering them both in depth in the next couple of slides. Using this link, which is the View and Update Consent answers, this grants you access to view the consent questions and answers entered at Reg. You can make changes to the answer if they were entered incorrectly or if the patient has changed their mind. If and when you do this, our database is updated and we receive an electronic notification of what you have done. The next link is Notify that specimen cannot be submitted. This is the link you will choose if specimens cannot be submitted for any reason. So for example, say a tumor block that is required for the study has already been submitted for a different SWOG study, or a specimen cannot be obtained. You would use this link and update that specimen cannot be submitted, and your expectation should be resolved immediately. The next is the reports link. It's where you find assay results if your study utilizes this feature. The administration link is where you can find any contact names and email addresses of people who will be automatically notified when a shipment has been received by the lab. If you have personnel changes, please update the contact addresses on the administration page. The last item is the Contact Us, which this will give you links to send us a message to technical questions should you ever have any issues with the system. When sending an email to technical question, please provide as much information as possible in your email, including patient ID number, initial study number, and if applicable, a copy of any error message or detail the exact problem you are having. And as always, there's a training module with the demo. So this is the next slide. All right, so this is the page that will show up when you choose Log a Specimen from the home page. First, notice the link to No Patient ID Yet. So this link is only for studies that allow path or cytology submission prior to registration. If your study requires submission of specimens prior to registration, you would choose this link to enter patient demographic information. The system will then assign you a SWOG patient ID number in advance of registration. If the patient ultimately registered to any SWOG study, you would use that patient number given to you in the SDS to register. If the patient is not registered, then the number assigned by SpecCheck will be erased. If the protocol does not utilize pre-reg specimen submission, you would not use this link or obtain a patient ID number in advance of registration. Note, all required fields on all pages in SpecCheck are marked with red asterisks. Fields not marked are optional fields. Step 1 of 3 to log a specimen is to enter the SWOG patient ID number, initials, and study number. Then click on the next step. All right, so this is step 2 of 3. Once you've entered the study number, only the specimens required for that study will appear on the screen, and you'll just simply click the blue hyperlink for which one you are submitting. Note the different columns and what they represent. If the study has more than one reg step, make sure you are Choosing specimen for the correct step. Be especially careful about the specimen time point since some specimens are sent more than once over the course of the study, and you don't want to choose the incorrect one. Notice that 2 options for baseline tissue are listed. You can see here, there's blocks and unstained slides. So when there are options for a specimen type, the system will offer all options and let you know which are preferred, but only one is required, and either specimen type will resolve the expectation. All right, so step 3 is the final step to logging your specimen. Notice that there are only 2 required fields in this step. While quantity is pre-populated to match study requirements, you do have the ability to change it, and it should verify that you're documenting what is actually sent. The contact information is set up by you and is optional, but it helps the receiving lab know who is to contact if there is any question about the specimen. If no contacts are listed and the lab has a question, they will contact the person who has logged a specimen as their name and telephone number is populated based on login. Once you have entered your information, simply click Log a Specimen. All right, so once you click Log a Specimen, it may appear that nothing has happened, but I assure you it does. So at the top, you'll notice that a green link has appeared in the upper left-hand corner, letting you know that your specimen has been successfully logged. Also, you'll notice a yellow light that appears notifying you that while you have completed the process of logging the specimen, it still needs to be shipped in the system. So when you choose Update Specimen at the bottom left, you can edit what has been entered for the specimen if you need to edit. You can also delete the specimen on the bottom left if at any point you feel like you had the incorrect entry. You can also log another specimen for this person, which skips step 1 of entering patient ID, patient initials, and study ID, and takes you directly to step 2 of logging a specimen. And you can also click the home page, which takes you to home. And then lastly, Specimen Manager to finish the specimen submission process. So, for the next slide, Specimen Manager will show you all specimens logged by the institution you chose in the first screen. So it is useful to know how to use the filters to create a list only of what you need to see. The filters are at the top of the Specimen Manager page, as you can see in this animation. You can filter by patient number, study number, specimen number, and shipment number. Then you can choose the status filters, which are right here. The system will default to not ship, so make sure you're choosing the status of the specimens you want to see. You can also filter by receiving lab number in case you want to know all the specimens you ship to a particular lab. Once you've made the choice, you would hit apply, and then it will give you the screen right here. So once you create a shipment, it will take you to the next slide. All right. Just for an example, for those of you who have been following, I'll be using a different patient ID in the screenshot so you can see the status update. By using the filter to choose one patient, you have 6 specimens shipped. 3 of them have been received by the lab and 3 are currently on the way. When the lab receives it, then the receive date column gets filled out along with the condition column. So this is the Specimen Manager. It combines your specimens and your shipment information onto one easy to read and navigate page. Please note, specimen expectations are not resolved in the SWOG database until you ship them in the system. The expectation for those specimens whose status is not shipped, which is right here, as you can see in the slide, has not been resolved. Also note that not shipped specimens can be deleted here. In case something was entered incorrectly or logged more than once, for example. You can put multiple specimens into one shipment if they are going to the same lab. Just click all the boxes that apply, then hit create a shipment. If shipping multiple specimens at the same time, make sure to include the packing list for each specimen in the box. So once you have chosen to create a shipment, step 1 is just verifying the information that you have already entered. If you need to make changes, you can do so by clicking on Add or Modify Shipment Contacts. Step 2 is verifying the pre-populated lab info. The comments is a place to put any pertinent instructions or requests to the lab. For example, if you're sending anything more or less than the protocol requires, you would explain why in this section. Step 3 is the final step where you're entering the shipment date. Note a future shipment date is allowed up to 5 days in the future, and you can also backdate the shipment. If you already sent a specimen but did not log it in, this is not a good idea and should be avoided at all costs. But if you have to backdate a shipment, you are allowed to do it in the system. Then print the packing list and ship the shipment. Note that once a specimen is shipped in the SCS, it cannot be modified, so ensure that all information is accurately depicted prior to hitting ship the shipment. Also note that shipping label can be generated if needed, but if using FedEx or equivalent, this is not necessary. All right, so this screen shows a successful shipment, as you can see at the top. The shipment number, context, lab address, and so on. You can generate a shipping label if needed, or return to Specimen Manager or the home page. For this example, we will click on the View Packing List, which is located right there. All right, this is what the packing list looks like. This is where the viewing packing list takes you. It opens a new tab and it shows you this information. Please print this packing list and include it with your specimens. You only need to print this packing list, not other screenshots. Please do not send us a copy of the packing list to the SWOG Data Center because we don't need it. The packing list has all the information that you need. It lists what you're shipping, consent responses, the shipment number, the barcode, who the shipment is by, and who you're shipping it to. It is a good reference if you need the lab contact information or other details listed on this document. A handy feature of this packing list is that if other items need to accompany your specimen, they are listed on the packing list. For example, if a study requires you to include a copy of the pre-study pathology report along with the specimen, it will show up here. As always, for help and reference, please remember that nearly everything is fixable in the system. It's not possible to ruin or break it. Also keep in mind that logging and shipping a specimen is about a 2-minute process, so if it takes you longer than that amount of time, you probably need to contact us. If you get stuck, there are resources at your disposal, like I just mentioned, us, or you can contact Technical Question. They're a great group of programmers. But also, you can also contact the assigned data coordinator for your study for assistance. So here's a list of all the DLs that we have for each study. And if you guys don't have any questions, that concludes my talk.
All right, thank you very much, Sean. There's not any questions in the chat, so I think you're good. So if you want to advance to the next slide, Bill, our next and final speaker for this session is Hannah Brown from Nationwide, who's going to give you some tips for specimen submission from the lab perspective. So I'll send this over to Hannah.
Hey, thank you so much. My name is Hannah Brown, and I'm a protocol coordinator over at the SWOG Biospecimen Bank. So a lot of the specimens that are used by the different protocols come through us. So we're going to give you guys a few tips about submitting specimens. Next, please. To give you a little bit of an overview of what we do, the SWOG Biospecimen Bank is part of the Biopathology Center at the Abigail Wexner Research Institute at Nationwide Children's Hospital. So a super long name, but essentially we're a biorepository and we serve a lot of major organizations such as SWOG, COG, NRG Oncology, GOG Foundation, SARC, and EET. Next, please. On an average day, we at the Biopathology Center receive anywhere from 100 to 160 packages at either of our receiving labs, and they can contain upwards of 1,000 specimens for all of the different groups that we service. We get a lot of different types of specimens, including FFPE tissue, fresh blood, bone marrow, urine, frozen blood products and urine, frozen tissue, and lately we've even started receiving stool samples as well. And we accept all specimen types throughout the week, Monday through Friday, and we receive blood and bone marrow only, fresh blood and bone marrow only on Saturday as well for immediate processing needs. So because we receive so many specimens from all of our different groups, it's really crucial that we get accurate and adequate specimen submission. That way it doesn't slow down our processing. Next, please. So some tips for specimen collection, some different areas of the protocol that can be really helpful. Section 9 is the study calendar that can give you a very general overview of when specimens should be collected, kind of a nice reference, but sometimes, you know, it's the section 15 goes in much greater detail and it just gives you more information about each of those. So I would say section 9 can be kind of like a good general overview, but I would go with the instructions in sections 15 over section 9, just because it gives you you know, more detail. Another section is that section 12, where if the protocol includes any pathology review or central review, that is information is contained there. And then we also have additional biospecimen processing and submission procedures on the SWOG website. It's under the Biospecimen Resources tab. It's very helpful there, and they also have some general specimen processing information that a lot of times the protocols will refer to, but if there's any protocol specific processing information, definitely follow what the protocol says over that general information. Another thing is that web page includes shipping laboratory addresses and some really helpful specimen labels that I'll kind of touch on here in a minute. Next, please. So the specimen labeling requirements, generally speaking, is SWOG patient ID, patient initials, date of collection, and specimen type should be included on all sample labels that you submit to the Biopathology Center. Additionally, you know, there might be some things stated by the protocol that, you know, if there's any additional requirements, you definitely follow the protocol instructions. And then for things like FFPE tissue, we do need a few more things such as tissue type being primary metastatic or normal, surgical pathology ID from the corresponding path report, and the block number as well. And if we don't have any of this information, it can, we need to reach out to you to verify it to make sure everything that we're putting into our system is accurate and complete. And this can, in some cases, delay specimen processing just depending upon the type of missing information, or it may even require a waiver because we can't assume any information. Next slide, please. So kind of how I had previously mentioned, there's a really helpful labeling template on that Biospecimen Resources page on the SWOG website. These templates you're able to print on those Avery 5160 labels, and they have a variety of types, some for you know, FFPE specimens, PK specimens, and fresh or frozen liquids. And this is really helpful because if you print off a sheet of those, then you know, it helps you not miss any of the labeling requirements because every specimen that's submitted must be labeled with these. Next, please. So some tips for preparing your shipments. You know, definitely double check that specimen labeling. You know, that's probably the #1 problem that we see are inadequately labeled specimens. And again, you know, the requirements for those are generally in section 15 or on the Biospecimen Resources website. And then we also, if you could verify the information that you enter on the STS packing list before you mark the shipment as shipped, just to give it a quick double check and make sure all of that information is correct and matches the specimen label. Just to, you know, that'll help speed things along. And then also if you can confirm that all of the required paperwork is included. Again, this is generally stated in the protocol, but includes the STS packing list, a copy of the redacted pathology report if you're submitting FFPE material, and making sure that the SWOG patient ID is on all of the paperwork that is submitted. That way it's easy to see, you know, what paperwork belongs to which patient. A little bit about redacting. Some of the information that we need, again, include that surgical pathology ID, the block number, collection date, diagnosis, gross description, things along those lines. Anything that's related to the specimen that could be helpful is the things that we need. Things that you can redact include things like the social security number, the MRN, account numbers, full face photographs of the patients. We don't need any of that information, and that can all be redacted. Next, please. Some shipping considerations. Unless it's otherwise stated in the protocol, frozen specimens or FFPE tissue can be back shipped, but we do ask that you don't include any more than 5 patients in one shipment in case something happens to the package. We've had packages that get delayed due to the courier, and you know, if you're submitting frozen specimens, they could be thawed by the time they're received here, so we don't want it to happen. You know, we'd rather that happen to 5 patients worth of specimens rather than 20 patients worth of specimens, because things do happen sometimes. But if you do batch ship, please make sure to package each patient's specimen separately. And if there's multiple time points per patient, then, you know, it's better to include fewer than 5 patients in the shipment, you know, just to, again, kind of try to limit the number of specimens in the package. And you also want to keep in mind that you're packing the specimens according to the season. Frozen specimens always need plenty of dry ice, whether it's winter or summer. You know, just put plenty of dry ice in the package, but ambient specimens you have to kind of take a little bit of consideration with in the warmer months. You may want to include a cold pack, not a frozen pack, but just like a refrigerated pack, unless you're shipping something like Struck tubes, which should not be refrigerated at all, so those should be set completely ambient, no cold pack. And then in the colder months, you know, if you're shipping those fresh bloods, they can get frozen if they're sitting out at a dock or something at one of FedEx's facilities for a while. So make sure you insulate it well with bubble wrap to keep those from freezing. And then again, just a reminder, please ship the specimens priority overnight. That way they arrive first thing in the morning at our facility, especially with FedEx. Our UPS delivery tends to happen early or later in the afternoon. So if at all possible, we prefer FedEx. That way the delay is not, or you know, the receipt isn't delayed and we can get those processed as soon as possible. Next, please. And then just, you know, remember that in terms of weather, when you're kind of thinking about where you're shipping it, you know, the weather where you are may be different than the weather at the FedEx stock, where they're going to be shipped, and may be different than the weather at the biorepository in Columbus, Ohio. So just kind of keep in mind all of those types of weather patterns that the specimen might encounter. And you can go ahead and hit enter a few times. I think there were some transitions in there. Next, please. Okay, thanks. Common specimen quality issues that we see. I'm not going to get super in-depth on this, but I'll just kind of touch a few of them. So specimens, we sometimes see that specimens should be frozen will arrive without sufficient dry ice and may even be thawed. So again, just make sure you're picking a big enough box for the specimens that you're sending, and including plenty of dry ice. I would say do a third dry ice specimens and then fill the rest up with dry ice completely. Some other things that we see is hemolyzed or clotted blood or bone marrow. Again, just making sure that you're adequately mixing, but gently mixing that, anticoagulant. And then specimens in cracked, broken, or leaking containers, make sure you're including lots of padding. If you can, please use plastic tubes. Especially if you're doing frozen specimens, only use plastic tubes. We've gotten some broken glass tubes before, and that's no fun. And then incorrect specimen type received. So just making sure that you're referring to the protocol. And if you have any questions about something that you're seeing in the protocol, feel free to reach out to us. We're more than happy to help. Next, please. Some other things, missing paperwork. So just making sure that you're submitting that STS packing list and pathology reports if you're submitting tissue materials. Missing information on the specimen label. Again, just kind of referring to those requirements and using those label templates it really will help with that. The STS packing list, not matching the specimens. Again, I just greatly recommend, just like a quick double check between the STS packing list and the labels of the specimens, just to make sure everything is correct before you put it in that package to send to us. And then again, if you do insufficient dry ice, that can cause problems, but just, making sure that you include lots of dry ice, even a little bit more than maybe you think might be necessary, because it will sublimate at a rate of about 5 to 10 pounds every 24 hours. So just keep that in mind. If it takes a day to get to the bank, then, you want at least 5 to 10 or 5 pounds, probably more. Next, please. And then I included some links here for some helpful sites we kind of covered. The biospecimen processing and submission procedures, that's that SWOG.org page that has the labeling templates, some specimen submission guidelines, a lot of which we've covered here today, and a whole bunch of other resources. Again, these are very general resources, so always refer to the protocol first, but this can be extremely helpful. And then I've also included a BPC kit management link, which, if there are kits provided through the protocol, you can go to this website to order some, request some, and you can also do, I believe some protocols have built in FedEx air bills and things like that. But, again, that will be more clear in the protocol. And if you have any questions, please feel free to reach out to the bank about that. Next, please. And then I've also included some contact information for both the solid tissue bank and the leukemia division. And like I said, we're always available and happy to help. Next, please. I think I saw a question come through.
Yes, there is one.
Okay.
It's from Stephanie Gam. It says, who should we contact if we shipped a specimen months ago and it still hasn't been marked as received in SpecTrack? It's been marked as delivered via FedEx though.
Yeah, that happens on occasion just because of our processes. If there's something that we need to contact the site about, that can cause a little bit of a delay in us marking the specimen as received. But if you haven't heard from us, it could just be that we can get a little bit backlogged sometimes just because we have so many groups and so much going on. But if you ever have any concerns about that, please just reach out to the bank and we'll get that resolved for you as soon as possible. You can email, you can send to the BPC bank at Nationwide or just call that number if you would prefer.
And one more from Joan Moore. Do the labels remain adhered to in -80 freezer, or is it best to write on the cryo vials?
I think the paper labels are typically fine from my experience in the lab. We have a separate set of cryovial labels that before they go into permanent storage, we will kind of use those to help affix the institution label to the vial. So I think that the paper labels are fine. If you prefer to write directly on the cryovials, that's perfectly fine. We see that a lot as well. But yeah, I think it's just whatever's easiest for the site.
Okay, great. Thank you very much, Hannah, for participating in the training course again. Looks like we don't have any other questions and have just a couple minutes left before the end of our session. I didn't have any closeout comments, but we do have a third session as a reminder tomorrow morning to those of you that are participating in the practicum breakout session. So again, it's going to be tomorrow morning from 10 a.m. to 12 p.m. Central Time. For those of us on the West Coast, that starts at 8 a.m. in the morning. And we'll join as a group very briefly, and I'll introduce what that session is about, and then all of you will be magically dispersed between individual breakout sessions to work through the practicum exercises with your facilitators. So I'd like to thank you all for participating, and we will see you again tomorrow. Bye.